Greetings. My name is Derek Wong. I do the favorite topic of everybody, which is usually put on the last day of the course, and that is inborn errors of metabolism. And I know it's a favorite because everyone remembers everything about their biochemistry class. We're going to have a good time, and I do not have any conflicts of interest related to the material in this lecture. Now, you will notice something different about the outline of this lecture versus the way maybe board review books are. The reason is that I did it by presentation. So in other words, I look at which disorders cause hyperammonemia, disorders of glucose metabolism, et cetera, and then there's miscellaneous at the end. The books will do, amino acid disorders, organic acid disorders. The reason I do it this way is that the boards, they give you clinical questions. And so they'll give you someone with a low glucose, for example, and it's better to at least categorize it that way. And if you want to study it the other way, certainly the board review books can help you. But I'm trying to make it so that there are certain key things that we remember so that it's not just a mass of facts. At the end, I have a little bit of a differential diagnosis listing with some key things that might come up on the boards as well. The first thing is that this is a quick and dirty guide to biochemical testing. You can use this to reference it. For example, if you have an amino acid disorder, of course you want amino acids, but you get down to plasma acylcarnitines, and those are often used for fatty acid oxidation disorders. And very long chain fatty acids usually means a peroxisomal disorder. And so if you have these questions and it asks you, for example, something about urine GAGs, you know you're in the mucopolysaccharidosis. This little table can help to sort of, limit the scope of what you're thinking about. Inheritance is important. Almost all inborn errors are either autosomal recessive or a few are X-linked. I will say later that X-linked disorders are important because they're easy to test and they happen to be a little bit more common. Pathology can result from a lack of a substance like glucose or the buildup of toxins. And if you think about that, it sometimes makes it easier to remember clinical symptoms. Many of these conditions are treated with D10 with electrolyte. You treat with D10 with half normal saline at 1.5 times maintenance. Well, why do we do that? It's usually to stop the degradation of various substances, including glycogen, fat, or protein. So for many of these disorders, the D10 will stop the breakdown of these substances and actually help the patient. Carnitine is given for a lot of these disorders in order to aid in the excretion of toxic metabolites. And that is a general principle. So here's my overview of metabolism. And here's the first case. So this is a common thing. This is a baby boy who was born full term. There were no complications. He was discharged at day of life number 2, which is usual. And then he started becoming irritable, lethargic, tachypnic. And of course, he was brought in. He got a sepsis workup, and it was pretty unremarkable. There was, no acidosis, and his lumbar puncture was normal. Someone thought, well, I've seen kids with issues with ammonia, so they got pneumonia, and the ammonia was high, and it's 300. So this is not like a mild elevation. This is a significant elevation. So the question is, you have this 4-day-old with tachypnia, hyperammonemia, and no real acidosis. So the first question is, what is the most likely category for the diagnosis? And I'll give you a few seconds for this. Okay, so the answer is a urea cycle disorder. And we're going to get into this a little bit more. But the other diagnoses, number 1, fatty acid oxidation disorder, this will usually give you low glucose along with it and feeding intolerance. And so this patient did not really have that. Glycogen storage disease will also give you hypoglycemia and will not give you hyperammonemia. Lysosomal storage disorders, in general, are slow presentations, and I have a whole section on that. Organic acidemias do give you hyperammonemia, but as the name suggests, they give you acidosis, and urea cycle disorders is the answer, and that gives you hyperammonemia with a normal bicarb. Hyperammonemia is like getting drunk in a way. First of all, you start throwing up, you get tachypnic, you get lethargic, and then if you get too much of it, you get coma and you can die from it. If you get severe hyperammonemia for even a matter of hours, you can have permanent developmental delay. Making the diagnosis can be the difference between someone who's completely devastated and someone who can, function quite well. And the thing with the urea cycle disorders is that these kids will poison themselves. So it's not like they can stop taking the ammonia, their own body produces it. If you have hyperammonemia, it implies urea cycle dysfunction. Sometimes it's secondary, but in the case of this patient, it's primary. And the urea cycle is over here. So what happens is that proteins, excess that we take in, get digested. And their carbon skeleton goes over to the left, okay? And the nitrogen portion goes over to the right, and it goes into ammonia. And this ammonia can't be excreted easily, so then it's taken by the urea cycle and converted to urea, which can be put in the urine, of course. If you stop the urea cycle, you, of course, back up the ammonia, and that's how you get hyperammonemia. This does not occur right away. And the reason is that in the fetus, the mom, of course, and the placenta are filtering all the toxic products. And so in this case, the placenta is the same genotype as the fetus, but the mom is also clearing ammonia for the baby. So when you are born, your ammonia is normal, and you don't have buildup of toxic products. It takes a while. It takes at least close to a day to accumulate these things and present. That's why it often happens at day 2 or 3 of life. And here's a little table. Now, if you look at the differential diagnosis of hyperammonemia, there are other conditions that can cause it, but those are more rare. They usually have other symptoms. And for the purposes of this talk, we really need to get to these two, okay? So yes, there's fatty acid oxidation disorders, and we'll go over the presentation later, but urea cycle, no acidosis. In fact, you have metabolic alkalosis, and organic acidemias, you have acidosis. Now, why do you have alkalosis with urea cycle disorders? The reason is that if you have increased ammonia, it stimulates your medulla oblongata to breathe faster for no reason. And so you overbreathe, therefore you get respiratory alkalosis. The tests that we use to diagnose some of these things are plasma amino acids and urine or orotic acid. The other thing that happens is that we can calculate the anion gap. Now remember, the anion gap is the sum of the positive ions minus the negative ions, and I leave out potassium. So in this case, the anion gap is 11, which is fairly normal. If you have an organic acid disorder, that has an unexplained anion gap because the organic acid contributes, just as if you have, for example, aspirin toxicity, that contributes to the anion gap. So the ammonia does not contribute, and the amino acids don't contribute in the same way. So this normal anion gap is consistent with a urea cycle disorder. How do we manage urea cycle disorder? Well, I talked about D10, and in this case, what we're trying to do is prevent the baby from breaking down his or her own muscle tissue. And the muscle is the main storage for amino acids. So if you need calories and you get past your glucose and glycogen, you get past your fatty acids, guess where you go? You start breaking down your own muscle tissue. And if you administer D10, you stop that process at least for a little while. The second way to do things is that there are scavengers. There's sodium benzoate, which is found in a variety of treats. If you go to the store, I won't name any names, but sodium benzoate is a preservative, but it also is a scavenger. And sodium phenylbutyrate is another one. And they take glycine and glutamine, which are two amino acids that are very close to ammonia. They allow them to be excreted as different forms. So they bypass the urea cycle by not using it. In severe cases where your ammonia is greater than 500 to 1,000 micromoles per liter, you need to get that ammonia down as fast as possible. And if you delay, and some people, they measure the ammonia again and again, or there's a delay in transport, That's when you get the devastating developmental delay from these conditions. And the fastest way to get ammonia down is to do dialysis. And that gets it down from these levels, or even 2,000 or 3,000, down to normal in a matter of a few hours. If you don't have dialysis at the institution you're at, you got to transfer them as soon as you can. I don't have all the structures here, but these are the key points. Your amino acids are broken down to ammonia, and the urea cycle converts it to urea. This is a diagram of some of the steps and some of the enzymes. So we have here carbamyl phosphate synthase, ornithine transcarbamylase, argininosuccinic acid synthase. This is the same thing, but it's a lyase, and this is arginase deficiency. These are in a table. It's not easy to remember all these, but the general idea is that most of these can present with severe hyperammonemia. And if you present with severe hyperammonemia, it's sort of the same set of clinical symptoms. And differentiating these on a clinical basis, I think, is beyond the scope of the pediatric boards. I do have a listing here, and this is for people who really want to delve into it. OTC is common, it's severe, it's X-linked. So this is the important one. And then there are other minor things here, but I'm going to go mostly over OTC. The classic presentation is just as we said in the case. So lethargy, coma, poor feeding, etc. There are less severe cases in females and some males. So this is not completely X-linked recessive, because X-linked recessive disease would not present in women, but this can, and it can present in fatal presentations. For example, in pregnancy, if you take certain medications like Depakote, if you have bariatric surgery and therefore you lose a massive amount of weight, females and less severe males can present later. It's also important that can be a positive family history. Oftentimes there's a maternal uncle who died at a very young age, and if that's the case, you really have to look at OTC. Remember, your urea cycle is disrupted, so therefore your blood urea nitrogen will be low. And people don't think of low BUN very much. Sometimes in babies, the BUN is less than 1 or 2, and it's not something that we normally see. Orotic acid is something that is produced by carbamyl phosphate. So you block OTC, you get the generation of more carbamyl phosphate. That actually goes into the pyrimidine synthesis pathway and therefore produces orotic acid. So this is one of the signs of OTC deficiency. It's not elevated in every urea cycle disorder, but it is elevated here. So that's why I put it. And then there are abnormal plasma amino acids. And in particular, there's low citrulline in OTC. If I block here, there's low citrulline, right? I get a backup of carbamyl phosphate, and then I have generation of orotic acid. So that's the characteristic. And you can see that if you do these plasma amino acids, because these things are all amino acids, you can differentiate OTC from ASAL or arginase deficiency by just looking at this pattern of amino acids. So that's why we get plasma amino acids in this condition. And the long-term treatment is we use protein restriction. There's special formulas which are lower in protein, and there's outpatient scavenger therapy. So again, you can help the glycine and glutamine exit the body in a different way. So for test purposes, if you have severe hyperammonemia without acidosis, it's usually a urea cycle disorder until proven otherwise for test purposes, but also in the real world. You got to think of that. Now, it can be something else, but you're going to be calling your friendly geneticist to find out. But it's something that you need to think about all the time, and it's the most common one. Now, here is another patient with hyperammonemia, and there's a question about this. So this is someone who has the same sort of presentation. She's normal size, normal birth history, et cetera. But this patient's kind of hypotonic. And if you look, there's severe acidosis. And it looks like there's pancytopenia. The white cell count, the hemoglobin, platelets are all kind of low, and the ammonia is high. So the question is, which of these disorders could this be? So I'm going to give you a few seconds on this one as well. So the answer to this is inorganic acidemia. So we went over urea cycle disorders. So you know that urea cycle disorders, they don't give you acidosis. Could you have sepsis and a urea cycle disorder? Yes, but we're not going to get that complicated. This is things that are just due to the disorder. So lysosomal storage diseases, glycogen storage diseases don't cause increased ammonia, and fatty acid oxidation disorders will cause hypoglycemia in addition, and won't cause all these other abnormalities. So this is an organic acidemia. So remember, the nitrogen portion of the amino acids goes into the urea cycle. The carbon portion is recycled. Remember that nature is very efficient, and it's recycled into the TCA cycle and other things. So if I interfere with the breakdown of these amino acids here, then I get organic acids. They're just acids made of carbon, hydrogen, et cetera, all the stuff that you remember fondly from organic chemistry. And these things cause toxicity. Yes, you may need the carbon skeletons, but most of us don't. It's the fact that you stop these reactions in the middle that causes the issue. These are 3 common forms of organic acidemias, or organic acidurias, as they're sometimes called. Most of you will have remember this from residency, that you might have propionic acidemia, methylmalonic acidemia, and isovaleric acidemia. These are caused by inborn errors of branched chain amino acid metabolism. So valine, isoleucine, and leucine. Why do the branched chains affect things so much? It's because the branched chain amino acids, those 3 make up 40% of the muscle. And therefore, if you break down muscle, you put a lot of flux through those pathways. And if you have an inborn error in there, you generate a lot of toxic intermediates. And some of these intermediates, even if they're in high quantities, don't really cause problems. But in these particular cases, they do. Here are 3 of the enzymes seen in organic acidemias. Propionic acidemia, the cofactor for the reaction is biotin. Methylmalonic acidemia, the cofactor is cobalamin. This actually can be confused with cobalamin deficiency, but the symptoms are much more severe. Isovaleric acidemia apparently smells like sweaty socks. I think it smells a little different than that, but that's the classic description. The presentation, okay, remember that babies don't do that much, right? They cry and they wake up and they feed. So if they're not feeding and they have decreased level of consciousness and coma, then you have to do labs. And if they have hyperammonemia and acidosis, then that implies that they might have an organic acid problem. Now, if you have sepsis, you can increase your ammonia, but not to the degree that these guys do. So the treatment is similar to that of the urea cycle disorders. You give D10 with half normal saline or normal saline, whichever you want, and you give it at 1.5 times maintenance to stop the breakdown of these proteins. The difference is you give carnitine. So remember I said carnitine reduces these toxic intermediates. It binds to the organic acids and allows them to be excreted. Sometimes you need dialysis, and for the same reason. If your ammonia is very high, you need to get it down, you need to have dialysis to get rid of it. And the chronic treatment is really special formulas, which are deficient in some of these amino acids, protein restriction, and carnitine. So it's a little bit different. You don't use the scavenging agents that you use in urea cycle disorders, because the urea cycle problem is secondary to these propionic or methylmalonic acid. I'm going to shift gears now from proteins to carbohydrates. Okay, so we're going to have a case of hypoglycemia. So this is a 4-month-old who presents after a seizure, and you suspect that it is a hypoglycemic seizure because the glucose was 27. This patient also has hepatomegaly with a liver edge 4 centimeters below the right costal margin. You get some comprehensive metabolic labs, and it turns out that there's increased uric acid and increased triglyceride. If you have hypoglycemia, hypertriglyceridemia, and hyperuricemia, what additional lab value are you likely to have? So if we look at the choices, we have abnormal urine organic acids. Remember, urine organic acids are found with propionic methylmalonic acidemia. They don't necessarily give you hypoglycemia or these things. They give you acidosis, pancytopenia, hyperammonemia. So that doesn't make sense. Lysosomal storage diseases are, again, slow presenting, usually after years. and they don't have a hypoglycemic presentation either. Elevated ammonia, well, we went over the organic acids and the amino acids, and that's not the presentation here. And it turns out that the answer is lactate, not pyruvate. So I'm going to describe glycogen storage disease type 1, and it turns out that the triad of abnormalities is triglycerides, uric acid, and lactate. In these patients, it's not like you have a glucose of 40 or 50 because you haven't eaten in a while. These are kids who go down to the 20s, 10, even unmeasurable glucose levels. So hypoglycemia often results from a deficiency of carbohydrate or fatty acid metabolism. There is a differential of what we call ketotic hypoglycemia. When you get hypoglycemic, your brain needs another source of energy. And your body has a ready source, which is to make ketones in the liver and send them to the brain. So having ketotic hypoglycemia is actually much better than having non-ketotic hypoglycemia because you still supply your brain with energy. If you have ketones and you have low glucose, some of these glycogen storage disease and other things will be in the differential. As opposed to non-ketotic hypoglycemia, we'll go over fatty acid oxidation disorders, which you can harm yourself because you have no source of fuel. So here is a condition now, the glycogen storage disorder, that can present with hypoglycemia. And here's carbohydrate metabolism, and we'll blow it up. So I'm going to concentrate not on these guys, which we'll get to later, but right here. This is glycogen storage disease type 1, and there's some other glycogen storage diseases here. What happens is that when we eat, we store glycogen. So your liver might have 50 or 100 grams of glycogen, a lot of sugar that's bound to each other. And so your body takes the glucose, or your liver, and it stores it as glycogen, and then when you fast for more than, let's say, 15 minutes or so, you use that glycogen and it goes back down and it makes glucose. It does not go down here because it needs to go back to glucose, and your liver sends the glucose to your brain and muscles and other tissues that want it. So if you disrupt this pathway, then what happens is after, maybe even an hour of fasting, you're out of energy. So in GSD1, this glycogen is prevented from turning into glucose at this point, right? This is glucose 6-phosphatase. So here's the relevant enzymes without all the muck in it. So what's the presentation of a glycogen storage disorder? Turns out that there are two different types of GSDs. One affects mostly the liver and one affects the muscle. The liver glycogen storage diseases present with systemic hypoglycemia, as you can imagine. So you get big liver because a lot of the storage products occur in the liver, so it's hepatotoxic basically. Also, you get very low glucose. You have doll-like faces, puffy cheeks, but you have skinny extremities. And the triad is in glycogen storage disease type 1, you have increased lactate, increased triglycerides, and increased uric acid. The diagnosis used to be made by liver biopsy, but now DNA panels are the way to go. And the treatment of this is cornstarch and nocturnal enteral feeding. So if you can imagine, cornstarch is like a form of slow-release glucose. So it's almost like glycogen, and it sits in your intestine, and it's released over time. So cornstarch is the thing that is used in this so that you don't have to feed someone every 2 to 3 hours. Okay, and if you can imagine feeding a baby every 2 to 3 hours, okay, that's okay. But if you have a 16-year-old, you don't want to be waking them up every 2 or 3 hours at night. That's really bad. So cornstarch lengthens that to 4 hours, and in some forms, you can get 6 hours with it. But that's still not great. Imagine being 25 years old and having to wake up in the middle of the night every night. It's still a very difficult disease to treat. Sometimes they get liver adenomas and they need a liver transplant. There are many different forms of this. Type 1A is a classic form, which I just described. Type 1B is the same, but it also has an immune deficiency. So you get neutropenia, you can get actually an inflammatory bowel disease-like picture. And then there are several other forms of this hepatic GSDs that have various different manifestations. One of these is type 9, and it may be X-linked or autosomal recessive. And the rest are all autosomal recessive. So we talked about the hepatic forms. Now, there are other forms of glycogen storage disease. There's muscle forms. Why are there muscle forms? Because the muscle can't wait for the liver to send it glucose. The muscle has to generate glucose on its own, because when you're running away or doing your Peloton, you need to have energy right away. A lot of these reactions take place in parallel in the liver and muscle, and they may have different enzymes. And so if you can imagine, if I shut off one source of energy for the muscle, what's going to happen? You're going to get weak. You're going to start cramping. And your heart muscle may not work as well. So some patients may have cardiomyopathy. The diagnosis of these used to be in all sorts of esoteric things, including muscle biopsy, but now we do most of it by DNA. And the treatment varies with disease. You actually may need, to have carbohydrate-rich diet before exercise. Your muscles use carbohydrates. They can use fats, but you need both of those fuels in order to treat this. Muscle glycogen storage diseases, there are several. Now, Pompe disease is more of a lysosomal storage disorder, but it is also a glycogen storage disease. I'm going to go over the presentation of that in a later section. Type 5 McArdle is classic form. This is caused by a deficiency of muscle phosphorylase. You have muscle pain and cramping, exercise intolerance, can have weakness, and the big thing is you can have rhabdomyolysis. So remember, with rhabdomyolysis, you have some sort of inciting event. It could be that you exercised an extreme amount, especially in a lot of heat, but this is also a risk factor here. You use all the energy up, your muscle cells lyse, and therefore you put myoglobin and a bunch of other toxins into your body. Instead of having a small amount of muscle cells lyse, which happens in normal exercise, you have a large amount, and that can cause a lot of problems. It can cause the red urine that they have, and you need to flush them out to prevent renal failure. So if you have rhabdomyolysis under a moderate exercise condition, then one of the differential diagnoses is one of these muscle glycogen storage diseases. And there's also, type 7, which is similar. The take-home message here is that if you have a baby with severe hypoglycemia and liver disease and lactic acidosis, you have glycogen storage disease type 1 until proven otherwise. So many of the questions will be on the hepatic forms. Now we're going to get to a second condition with hypoglycemia. So here's a 6-month-old who gets a fever, gets lethargic, has a low glucose, and has a normal urinalysis with no ketones. And it turns out the baby's sister died at 1 year of age after an episode of gastroenteritis, and they thought it was SIDS, which 12 months is, borderline for the age range for SIDS. But then you kind of put things together. You say, well, wait, why did she die with gastroenteritis? And this kid got sick with something else. So here's the question, and I'll give you a little bit to answer it. Okay, so remember I said hypoketotic hypoglycemia is bad. And that's bad because your glucose is not available to supply the brain with energy, and the ketones aren't available. So if you have the lack of both of those, you're in big trouble. And so this is a specific set of disorders. Now, if you have congenital hyperinsulinism, you can have low glucose. Usually, though, you will have this all the time, including when you're eating, and right after you eat, the insulin keeps going. Whereas this is more fasting problem, right? And so that's how you differentiate some of the congenital hyperinsulinisms from fatty acid oxidation disorders. We'll go over fatty acid oxidation disorders, which is the true answer, of course. Galactosemia, you can have hypoglycemia, but you'll have liver disease and other things. You won't necessarily have hypoketosis, and you won't necessarily die. Hereditary fructose intolerance, again, it's not the same presentation because you have it after you eat something with fructose in it, and it doesn't cause you to have that severe hypoglycemia unless you have a lot of other liver problems. And infant of a diabetic mother, you get hypoglycemic, but that's much earlier in the course. It's usually within hours of when you're born. So we're going to talk about fatty acid oxidation disorders. So remember, fatty acids are very efficient generators of energy, and they break down into acetyl-CoA, involved in a lot of different processes, including going into the TCA cycle or making ketones. So you can imagine that if you don't have a fatty acid metabolism that's intact, then you will make less ketones. There are other ways of making ketones, but your ketone production is going to be less. Most of the fats that we eat are what we call long chain. So they're 16, 18 carbons. So remember these little organic chemistry diagrams. You can have medium chains, which are about 8 carbons, and the acetyl-CoA is 2 carbons. So we have these fats, and they're sitting out in the cytosol, and we want to use them for energy. The energy generation is done in the mitochondria. So these long chain fats, they can't get through the membrane very easily because it needs a carnitine transporter system, because the fat just can't transport itself across the membrane. After that, the fat is broken down in a series of reactions every time you chop off 2. So you go from 16 carbons to 14 to 12, et cetera. Every time you chop off an acetyl-CoA. So that's why fats generate energy so efficiently, because that 16 carbon fat molecule generates 8 acetyl-CoA molecules. That can go into energy, or it can be used for ketones. Now, one other thing to remember is that if you have a medium chain, an 8 carbon fat, it can go right in and bypass this whole carnitine system. Basically, there's a lot of different disorders that can affect all of these things. Now, again, this is beyond the scope of this lecture. But the big thing is that there's things that I call long chain disorders. And that can be all of the stuff that affects this part of the reaction. And then there's medium chain disorders that can affect this part. And so we're just going to talk about those 2 in general, and you'll get the idea. MCAD deficiency affects this part. A deficiency of medium chain acyl-CoA dehydrogenase. Now, why is this important? This was one of the causes of SIDS. It would present that the child had a cold or a mild gastroenteritis, and they wouldn't wake up the next day. And of course, SIDS is the worst possible thing that can happen. I mean, there's nothing worse than having a healthy baby who suddenly dies. Some of these kids, they had low glucose, they had low ketones, and then they did some genetic testing, and they figured out that some of these kids had MCAD deficiency, and that there was a common mutation in Caucasians. And in fact, that's why this was put on the newborn screen, because it's fairly common and it's preventable. And how is it prevented? All you do is you do fasting avoidance. Now, that's sometimes harder than it seems, but basically, if an infant is not eating because they've got a viral infection, gastroenteritis, or other problem, you don't leave them alone. You give them dextrose fluid. So you give D10 at 1.5 times maintenance, the magic treatment for 80% of these metabolic disorders, right? And if you give them that, and you don't have a big excess of fat in the diet, you prevent all that sudden death. That has been a great success story. Anyway, you might come across some babies who screen positive for this, and that the treatment is easy, but in the first year, of course, it's tough because you have to wake them up sometimes. There are a lot of other disorders, and there's names that are long here. I'm just putting them on here, though, just to show you that there's all these different disorders. Okay, and they present in the same way. So these are the ones that affect long-chain fatty acids. And again, we have the same thing, hypoketotic hypoglycemia. So if you learn one thing from this, that is a sign of a fatty acid oxidation disorder. They can cause liver disease, mild hyperammonemia. They can cause sudden death as well. Similar to the glycogen storage disease, if you run out of energy, okay, this time you're running out of fats, not glycogen, but if one of your 2 sources of energy runs out, you can get cardiomyopathy because your heart fails because of lack of energy, and you can get rhabdomyolysis. The other thing is some of these patients have retinopathy. The treatment of this is similar to MCAD. So fasting avoidance. The other thing is that sometimes we give carnitine because carnitine is necessary to have the reaction. So if I block something up here, if there's toxic intermediates in this area, if I give carnitine, it allows that to exit. So that's why carnitine works in this. If I also block here and I have a deficiency of energy, if I give a medium chain fat, it bypasses all this stuff and it goes right down and it gives you some energy, not as much as if you get a long fatty acid, but certainly enough to save you. Now, we have another form of hypoglycemia. This is a 7-day-old with irritability, lethargy, and jaundice, and hepatomegaly, so some liver disease present at a very early age. The exam shows bilateral cataracts, and the blood culture is positive for E. coli, and that is important. So which of the following is a likely diagnosis? Okay, so one thing you got to remember is that galactosemia, which we're going to talk about, is related to E. coli sepsis. Yes, it doesn't happen very much anymore because of the newborn screen, but do they love to test on it? You betcha. They're obsessed with E. coli sepsis and galactosemia, so we might as well take advantage of that. So remember that connection. Gaucher disease is a lysosomal storage disease that usually takes a long time to present. There are very severe forms of lysosomal storage disease that present in infancy, but not like this at all. They present with sometimes high drops. Glycogen storage disease, it does give you hypoglycemia and hepatomegaly, but it does not give you cataracts and it does not give you E. coli sepsis. Fructose intolerance, similar, hypoglycemia, hepatomegaly, it doesn't give you these things. And tyrosinemia gives you liver disease like these patients have, but won't necessarily give you the cataracts and the hypoglycemia. While it's mild, it's nothing like what you'd see with galactosemia. So this is the answer. And here's our pathways, and I'm going to reduce this. So this is the enzyme in classic galactosemia. It's a transferase enzyme. And while you can convert glucose to galactose, et cetera, I'm going to concentrate on the pathway that takes place in the newborn, which is that, remember that either breast milk or formula, most of the formulas will have lactose in it. Lactose is a sugar which breaks down into galactose and glucose. And glucose, of course, is used readily. Galactose is used in some glycoproteins, so it's used to make that, but it's not used that much. And so you have to recycle the rest of the galactose. Otherwise, you waste almost half of your energy. And again, nature's efficient. So what happens is the galactose is converted to glucose 1-phosphate and is sent, and it can make glucose. If you have a block here, that is a problem, first of all, because almost half your energy is gone, but second, because you accumulate this galactose 1-phosphate. Anything with phosphate in it is potentially toxic to the liver. It's because you can't generate ATP. You get hypoglycemia because you run out of energy, but also that the phosphate itself is reactive. So this is a big problem. Classic galactosemia gives you the following symptoms: liver disease with coagulopathy. It gives you cataracts, and the reason it gives you cataracts is that it backs up and it gives you galactose. There's something called galactitol, which is an alcohol which is made that causes cataracts. You get sepsis, E. coli. Don't ask me why, but it just happens. It's easy to treat that because you have lactose-free formulas. One example would be most of the soy formulas in newborns. And if you put them on that, all these symptoms resolve. Problem is that galactosemia is not completely solved. Many of you have seen older galactosemic patients. Oftentimes they will have trouble in school. They have trouble holding jobs. A lot of them have to live at home with their parents. They have some neurologic deficits and dyspraxia. And women have almost 100% ovarian failure. Your body can make galactose from glucose. So even if you cut off all the external galactose supply, you have a low level of galactose that's being synthesized, and that causes these chronic symptoms. So that's why galactosemia, even though it seems like a simple disease in newborns, is not so simple. But it is important to diagnose. There's also something called galactokinase deficiency. That is a block. If you block here, you don't get the generation of galactose 1 phosphate, and therefore you get many fewer symptoms. But remember, you block here, you have galactose, which is okay, and that generates galactitol, which causes cataracts. So the main thing with galactokinase deficiency is that you have bilateral cataracts, which are reversible if you catch them early enough. Sometimes you have CNS problems. I apologize for the slide. You have intellectual disability. So that's the galactose pathway. There are other conditions. One of them is hereditary fructose intolerance. So fructose, remember, is mainly from fruits, but also sucrose, okay, which is present in a lot of the diets. Unfortunately, the Western diet is loaded with sucrose. These kids will not usually present right away, but once you start getting a lot of fructose, and especially sucrose, you get liver disease and growth failure. And you can also have a lot of other things. But a lot of times, the presentation is really that they avoid the sucrose and fructose. So these are the kids who don't want to go trick-or-treating, which is not very many, right? They just don't want to eat candy. And sometimes as adults, they have great teeth they really don't want to eat. And then you realize what's happening. It's diagnosed usually by DNA analysis. And the treatment is to avoid fructose and sucrose, which can be harder than it looks. But once you do that, this condition gets better. This is not screened for by the newborn screen. And it's something that's important to be aware of because it can be more subtle. The third thing that people think about is acidosis. And when people say acidosis, they say, oh, it's a metabolic disorder. And I'm going to tell you, most acidosis is due to sepsis or some other cause that is readily treatable. So it's okay to think about inborn errors, but put them low unless there's something else going on. So here's something that can indicate something. So if you have an anion gap, you need to look at lactic acid. Lactic acid can be caused by all these inborn errors, but most of the time it's due to tissue hypoxia. If you have congenital heart disease, if you have sepsis or something else, even after you restore the perfusion, you have to wash out all that lactic acid. You have to look at what's common first and get rid of those causes. Now, if you have a big anion gap and you haven't been poisoned and you have no explanation because the lactate is not elevated, then you think, okay, well, maybe is an organic acid or something else going on. Or if it's lactic acidosis and you really don't have any problems with perfusion and it persists, then maybe, yes, you do have all these things. But in general, 98% to 99% of acidosis is not caused by an inborn error. So these are the things that you look for, the patterns, if you have acidosis, that might key you into a different diagnosis. So acidosis and hyperammonemia, as we said, organic acidemia. Acidosis and hypoketotic hypoglycemia, remember, that could be fatty acid oxidation disorder. Lactic acidosis and hypoglycemia, it can be GSD or hereditary fructose intolerance. Usually it's severe hypoglycemia. And if you have very high lactate without other causes, then sometimes you think about mitochondrial disorders. But these things are thought about in academic medical centers to the exclusion of everything else. Most of the time, very high lactate is something else. So remember that. So right now, we're going to talk about some other conditions that have different presentations and are not easily categorized into one of the major things that I did before. Some of these conditions are amino acidopathies, and they interrupt the metabolism of amino acids before it gets down to the urea cycle and branches off into the organic acid problems. So here's one of them. When you think of tyrosinemia type 1, that is really hepatic failure. It does also cause renal failure later, but the big thing is it can cause liver failure, coagulopathy, jaundice, and then later renal tubular acidosis. They do describe a cabbage-like odor with this. People say, well, you have increased tyrosine, you have tyrosinemia. That's not the only thing, though, because tyrosinemia, you can have other things that cause it. Tyrosinemia type 1 metabolite is succinyl acetone on urine organic acids. I have seen that on some board questions. It requires NTBC therapy. I cannot expand this without taking up 6 lines, but basically it's an insecticide that didn't work very well, and so we give it to kids. But it does block the correct pathway, treat the tyrosinemia. And some people are on it for 20 years, and it has actually resulted in much better care of these patients. You want to reduce the production of succinylacetone. Later on, these patients can have liver cancer and require liver transplantation. But because of the succinylacetone, this has been put off for many, many years. It used to be in kids, and now it's in much older adults. Here's the block in tyrosinemia type 1, and you can see that it's far down. Tyrosinemia goes through many, many iterations. This succinylacetone actually blocks this enzyme, so therefore it causes you to have increased tyrosine in an indirect way. What you do with NTBC, you block the generation of this succinylacetone. Now the problem is you still have increased tyrosine, and if you have increased tyrosine, you get tyrosinemia type 2. In order to prevent that, you have to go on a low tyrosine diet. So the treatment for tyrosinemia type 1 is NTBC and a low tyrosine diet. If you have tyrosinemia type 2, the treatment is a low tyrosine diet. Tyrosinemia type 2, which is caused by just an increased tyrosine but no increased succinylacetone, is called oculocutaneous. So if you remember oculocutaneous, it's easy because their eyes have erosions, their skin, you can have keratosis of the palms and soles. They may have intellectual disability. You diagnose this with plasma amino acids, but of course then you need genetic follow-up. And it's treated with special formula and diet. Again, not as well developed as, for example, PKU formulas, so does not taste good and very difficult to give if you diagnose it late in someone. The second condition that I'll talk about that's in the miscellaneous category is glutaric acidemia type 1. And this is important because infants developed macrocephaly and subtle neurologic signs, so they can have hypotonia. But this creates a catastrophic event in some of these patients after a viral infection, usually at about age a year, 18 months, and all of a sudden they have a big stroke in their basal ganglia. And it leads to severe intellectual disability and movement disorder that is almost impossible to treat. Retinal or subdural hemorrhages, and so in this condition, early on, it can be mistaken for child abuse, but there are laboratory studies that you can get or genetic testing that really rules it out. The treatment of this is based on the fact that glutaric acid is a byproduct of lysine and tryptophan metabolism. So you give a special diet that's low in those, and then you avoid fasting. The glutaric acid and other things are toxins, so you give carnitine to get rid of that. And if you do all those three things, the idea is that you prevent having strokes in childhood. And by the time you reach 8 or 10 years, then the risk of strokes is much less. And so you've dodged a bullet. Some of these patients are still hypotonic and still delayed, but much, much less so than they would have otherwise. Biotinidase deficiency can be a dramatic presentation, and this is the easiest condition to treat. So biotin is a cofactor for various carboxylase enzymes. And suffice it to say that all 4 of these enzymes are critical to metabolic functioning. So if you have biotinidase deficiency, you don't recycle biotin well, and therefore you effectively have a deficiency of it, and you have interruption of all these enzymes, and it causes acidosis and metabolic decompensation, similar to the organic acid problems that we talked about before. That's severe biotinidase deficiency. There's also partial biotinidase deficiency, which causes rash and alopecia. These also are present in other forms, more severe forms of biotinidase deficiency. This is so easy to treat. You give biotin 10 milligrams a day, and that's available in lots of places. So as long as they take the biotin, they're fine. Maple syrup urine disease. This is a classic disorder that is differentiated by the smell. Well, the problem is if you wait till that time, the patient's usually in a coma, which is why this is also on the newborn screen. This is something that doesn't usually cause severe hypoglycemia. It can cause hyperammonemia, but a lot of times it doesn't. And it doesn't usually cause acidosis. The only thing it can cause is ketosis. So that's why it slips through some of the workup. Remember, people say, their glucose is normal or pneumonia is normal. They're not acidotic, therefore they don't have an inborn error. Well, this is one that is very important. You get increased leucine, and the leucine basically causes encephalopathy. Not only do you get poor feeding, but you get seizures, you can get this maple syrup smell, And then later on, you can get ataxia and significant developmental delay. Diagnosis is often made by plasma amino acids because these 3 branched chain amino acids are affected. So this is a block early on in leucine, isoleucine, valine metabolism. You have to restrict leucine, but it used to be thought you had to restrict these 2, but now it turns out that you have to supplement these 2 so they can get into the cell because leucine blocks this transporter. Treatment is evolving. The basic thing is you need the standard treatment, which is D10 with half normal saline or normal saline at 1.5 times maintenance. There are times when you need dialysis to get rid of that leucine so it doesn't damage the brain completely. Thiamine is a cofactor, so in some mild cases, it works to reduce the severity of the disease. There are conditions where you have progressive and systemic and neurologic symptoms. These are not the ones that have dramatic presentations like hyperammonemia. These are the ones that slowly build up. And so if you think about that, at least you can get an idea of things that are in this category. So this question deals with a 6-month-old who has developmental regression, startles very easily, and has a cherry red spot on ophthalmologic examination. There are several things that can cause a cherry red spot, but Tay-Sachs is the classic example of this. The other thing is, in Tay-Sachs, there is an easy startle reaction, and they, for some reason, love this on tests. But clinically, it's important too, but if you have a regression and poor feeding by itself, you don't need an easy startle to figure out that you need to send this kid to someone who can work them up. But none of these conditions have cherry red spots. We'll see the other symptoms of the condition later. If there's steady decline in milestones, that can be a sign that there's something that's causing progressive damage. Of course, you can see neurologic abnormalities and you can see storage, especially in the liver and spleen. And so it's important to get a good abdominal exam. And MRI, of course, is very important because sometimes if they do store material in the brain, you'll see it on MRI. Here is a general diagram of some of these conditions. Why am I going over these particular ones? Because not in Tay-Sachs, but in the other conditions, there's actually treatment. And so making the diagnosis is very important because you can alter the course of the disease. Tay-Sachs disease is a deficiency of beta-hexosaminidase A. And of course, it's common in Ashkenazi Jews because of the extensive screening programs. The incidence of Tay-Sachs is actually more in non-Jews than in Jews. It's because programs have been so good. And sometimes people say, oh, you can't have Tay-Sachs because this patient's not Jewish. That's a bunch of nonsense. So the classic form is increased startle, decreased attentiveness, neurologic decline, and death and cherry red spot. And still, to this day, there's no treatment. So this is glucocerebrosidase deficiency. Now, the most common form is type 1. And it's common in the Ashkenazi Jewish population as well. Types 2 and 3 have major central nervous system involvement. In type 1, what you get is osteopenia, osteonecrosis, and fractures. For example, you might get them at age 20 or 30 instead of, when you're age 85 or 90. And the problem is that if you diagnose it at age 25 or 30, your bone mass is already very low. So it's hard, to get that back, especially since the Gaucher cells, which are present on the bone marrow biopsy, infiltrate the bone marrow. I can't tell you how many people have Gaucher disease and no one's ever felt their abdomen, and they've got massive livers and spleens. You have anemia and thrombocytopenia, interstitial pulmonary disease. But most of the thing is that you have hepatosplenomegaly, some mild anemia, and these fractures. And then the severe forms, type 2 and 3, can give you developmental regression. The very severe forms, you'll pass away at a very young age. You can do enzyme activity. Genetic testing is readily available because there's treatment. On a bone marrow examination, you get the presence of Gaucher cells. There are several forms of treatments now. The most common is enzyme replacement, and that helps in type 1. In type 1, it really reduces the size of the liver and the spleen, and it can help bone disease over many, many years. And so it really, has been a great treatment, but it does require IVs, and, every week or two you get, IV therapy. The thing is that there are now oral forms of some of the medications that work almost as well for type 1, which is the most common. And so there are other ways of treating this which are coming out. Splenectomy is not recommended. The next lysosomal storage disease is Fabry. Fabry is X-linked. Remember, X-linked is important. It affects the small blood vessels, and females are often symptomatic, just not as early as males. So the classic clinical features, angiokeratomas, these little red bumps, pain crises in distal extremities. So these are burning pains that happen in your arms, your hands, feet, arms, legs, and they're often ignored. A lot of times women come in and they get ignored, but pain crises are one of the earliest symptoms. They can have all sorts of other things from GI to many, many other conditions. And then later in life, they get renal failure, they get strokes, they can get cardiomyopathy, but those are usually way outside the pediatric range. So in peds, these are the guys that you want to concentrate on, the pain crisis and the angiokeratomas. Genetic testing is available, enzyme is available. There's enzyme replacement. It helps with some of the symptoms, not with all of them. Definitely worth treating because it often helps the pain crises, but it takes a while. Pompe disease. Now, if you remember, in the glycogen storage disease, one of them was Pompe, because this is actually an enzyme that's used in glycogen metabolism inside the lysosome. So I think of the lysosome as a big recycling factory, and aluminum cans, bottles, paper, everything goes in and it gets recycled. But if I break the aluminum can recycler and the stuff keeps coming in, that factory is going to get filled with aluminum cans, and eventually, if you stuff it in hard enough, that factory is going to burst. These lysosomes in these conditions get really big because there's one deficiency that causes the buildup of one particular thing. And in Pompe disease, this causes a problem with your muscles. And so the infantile form has severe weakness. And I'll give you an example. Some of the patients with the infantile form before the advent of treatment, the only thing that they could do was blink, and they couldn't move any other muscle. So the late onset form, which you could have even into adulthood, which has progressive weakness progressing to respiratory failure. And you can imagine that if you had a milder mutation, then you could possibly get a late onset form. This diagnosis, again, by enzyme assay and DNA, and there's enzyme replacement available. Now, what's not on the slide, because it's probably not going to be in the boards, is if you treat it late, oftentimes you'll get less efficient response because your body will develop antibodies to the enzyme. So there's actually many treatment regimens that they use with all sorts of antibodies and things to try to get rid of your immune response so the enzyme can get to where it can work. Pompe is put on the newborn screen, by the way, as well. Then we get to the MPS, and this is actually the subject of a lot of classes for pediatricians. It's because the drug companies make a lot of money from the enzyme, and it's great that they do make the enzyme, but they also have money to educate everyone. And in these conditions, in these mucopolysaccharidoses, okay, which I will go over several of them, you have storage in the liver and spleen, in the bone, in the central nervous system. Here are some of the common features, but that's not in all of them. Coarse facies. So they're very hirsute. They have big heads. They have macroglossia, which means a big hunking tongue that can't fit into the mouth. They have growth failure because even though this is a storage disease, it interferes with the bone's ability to grow. They have severe hepatosplenomegaly, and their abdomen protrudes enough that they've got umbilical hernias, and sometimes they have very bad skeletal disformities. And the name for this is dysostosis multiplex. It includes a lot of things like oar-shaped ribs and vertebral abnormalities. The diagnosis of these MPS diseases is using urine gags, and these are the substances. These things are basically complex substances that exist in the extracellular matrix, so between cells, sort of like collagen, and they help with the structure of entire architecture of the cells. There is leukocyte enzyme testing, and of course there are genetic panels that are available. And here are some specific diseases. I will go over some of the key features of them, but Hurler and Hunter are two similar diseases, and they're the classic examples of MPS because they're early onset. You have coarse features, you have hepatosplenomegaly, and you have central nervous system deterioration in the severe forms. So basically, you start having developmental regression in the first few years of life, and unfortunately, you die even with enzyme treatment because the enzyme treatment doesn't cross the blood-brain barrier. People always ask how you differentiate Hurler from Hunter. Two ways. Number one is Hunter is X-linked, Hurler is autosomal recessive, and Hurler has corneal clouding. Hunter is listed as not having corneal clouding. Now, that's not completely true because there are people who say you can see this, but for the test purposes, that is the difference. Sanfilippo is something that doesn't have as many coarse features, but it has very bad cognitive decline. Morquio is basically a skeletal dysplasia, severe skeletal manifestations, and is autosomal recessive, and Hurler has corneal clouding. Hunter is listed as not having corneal clouding. Now, that's not completely true because there are people who say you can see this, but for the test purposes, that is the difference. Sanfilippo is something that doesn't have as many coarse features, but it has very bad cognitive decline. Morquio is basically a skeletal dysplasia, severe skeletal manifestations, and Meritola-May is mostly the skeletal and other manifestations, but without the neurologic. I have this off-color, ridiculous slide. It took me hours and hours to make it. If you have a disorder that affects heparan, that affects your central nervous system if it's severe. So if it's MPS1, Hurler, Hunter syndrome, Sanfilippo, the various different types, and type 7, which I'm not going to talk about because it's so rare. But those all can affect your development. If you affect these other things, it can affect your bones and or your growth and make you look like the pictures, but not necessarily your central nervous system as much. Types 1 and 2, Hurler and Hunter, will have both CNS and non-CNS effects, but type 3, Sanfilippo, will only have the CNS effects. You might look a little coarse, but not nearly as bad as the other patients. MPS 6, you have the skeletal effects without the CNS, and MPS 4 is the one where you have skeletal dysplasia, also not affected the CNS. So this helps me at least figure out which ones have which. And if you want to slide with that, here it is. So you have 1, 2, and 7 have CNS and systemic symptoms, et cetera. Other disorders of regression. A 6-year-old with intellectual disability, chorioathetoid movements. So in other words, these really odd twisting movements, and self-mutilation. Okay, that tells you something. And a family history of a similarly affected uncle, which of course happens to be on the maternal side. Labs include a marked elevation in uric acid. So here's a question. So this is a classic presentation of Lesch-Nyhan syndrome. Other conditions, glutaric aciduria type 1, remember that is really, subtle hypotonia, macrocephaly, and strokes viral syndrome. So that's not right. PKU, which we'll talk about in a bit, is really progressive intellectual disability if it's untreated, but it doesn't have necessarily the chorioathetoid movements and the self-mutilation. Smith-Lemli-Opitz and Zellweger, we'll talk about later, they're dysmorphic syndromes that have severe developmental delay. You want to differentiate those with a catastrophic course and those with a steady course. So Lesch-Nyhan, this is an X-linked disorder of purine metabolism. So what happens is you have to recycle purines. Okay, so remember, purines are used in making DNA, and you have to be efficient. If you let all those purines go, you're in big trouble. The classic signs, though, this self-mutilation, if you see self-mutilation, that could be Lesch-Nyhan. Chorioathetosis, those movements, you get hyperuricemia. Here's what happens. Here's the purines, okay, and they get recycled. If I fail to recycle them, guess what? It pours down into uric acid and it gives you gout and other things. So the diagnosis is by DNA, but the clinical features are pretty impressive. And the treatment, unfortunately, you can give allopurinol to reduce the uric acid, but it doesn't really treat the intellectual disability or other symptoms. So we need some other treatment of that. Maybe one of you will find it. PKU, this is a deficiency of phenylalanine hydroxylase. This converts phenylalanine to tyrosine. The cofactor is biopterin. The classic presentation is because you have very high phenylalanine levels. Phenylalanine is neurotoxic, especially in the fetus, but also in young children. So if you don't treat it in infancy, you get severe intellectual disability. And that's why this was the disorder that really got newborn screening started. And of course, you can also diagnose it with plasma amino acids because phenylalanine is an amino acid, and you can figure out that there's high phenylalanine and sometimes that there's low tyrosine. They divide phenylalanine up into all these categories, and I think this is going away. And I don't necessarily think they're official terms, but you can now just say they have classic PKU and they have a milder form of PKU if their levels aren't as high. But the levels normally are less than 2 milligrams per deciliter, which Usually they'll now give micromoles per liter, less than 120. Of course, the conversion is 60 to 1. If you have a very high phenylalanine level, you have to get that down in infancy or they'll rapidly become disabled. There's also pterin defects, and these affect neurotransmitters. They are completely different than PKU. Their treatment is different. You can actually make it worse by giving a low feed diet in some cases. And so that's why when you do a newborn screen and you get a high phenylalanine level, you can't just diagnose them with PKU and go away. You have to get these special tests. And if those are positive, of course, you should send them to the geneticist. But just remember that the high phenylalanine does not always mean PKU. So you think, okay, I can restrict the diet by phenylalanine and it cures it. Well, the problem is that is not as easy to do as you think. It's easy if you feed an infant special formula, but feeding a teenager while their friends are having pepperoni pizza is just not very, very good. And they tend to sneak out. They're not quite as affected. Their levels can be quite high. And the problem is that this affects executive function. There are other things that we can treat. This is a cofactor sapropterin, which is similar to biopterin, and it lowers the phenylalanine level in some mild patients. So about 30% will be responsive to that. Then there's newer treatments. This is a bacterial enzyme, which is unlikely to appear on the boards, but it is an FDA-approved treatment that digests phenylalanine via an alternate pathway. It's also important to know phenylalanine is toxic, especially to the fetus. And not only is it toxic to the central nervous system, it's a teratogen. So it causes microcephaly by restricted brain growth, intellectual disability, okay, but also problems with growth, and it causes congenital heart disease. So it turns out that if you had these moms with PKU, the babies had all sorts of problems. And it turns out because the moms weren't well controlled, the babies had effects from it. So you have to treat the mothers with a very strict restriction of phenylalanine during pregnancy. And then the babies turn out fine. Paroxysmal disorders. This X-linked adrenoleukodystrophy actually been the subject of some films. Usually you have a male who's kindergarten age and they start having behavior changes. They have attention deficit disorder when they say, and then the teachers say, well, a lot of kids this age have that. But then they have progressive cognitive decline, vision and hearing impairment, and they die within a few years. It's really bad. Adrenal dysfunction can occur, and carrier females can have spinal disease with gait impairment and loss of sphincter control when they're 40 to 60. So this is not completely X-linked recessive, but this is the form, the severe form that we need to talk about. This is a disorder of very long chain fatty acid oxidation. So it turns out that there's these very long chain fatty acids that are like 26 carbons long, and they are digested in the peroxisome, not in the mitochondria. X-linked adrenoleukodystrophy is a problem with the transporter, so they never get into the peroxisome. There's actually something called Zellweger syndrome as well, in which all or many of the reactions in the peroxisome don't take place. So the peroxisome might have 50 enzymes in it, and if you affect one, you can have X-linked ALD. If you affect all of them, you can have Zellweger syndrome, which is a much more severe disease. X-linked ALD, you have elevated very long chain fatty acids, and you have a mutation in this gene on the X chromosome. The reason that it's important is that there used to be something called Lorenzo's oil. They said it works. It doesn't really work. There is stem cell therapy, and that's effective if you treat it before the onset of clinical symptoms. So the problem is that most of these kids come after they're delayed, and that's too late to treat them with stem cell transplant. So that's why this is a newborn screening disease. If you have a sibling, obviously it's easy to figure out whether you have XALD. But if you are positive on the newborn screen and get followed, then they can follow your MRIs. And once you get any evidence of disease, even if you haven't developed symptoms, they treat you and the outcome is much better. There are some metabolic disease with dysmorphic features. One of them is Zellweger syndrome. As I said, this results from multiple enzyme deficiencies in the peroxisome. If you Google this, the picture is worth 1,000 words. Basically, they have a very, very large head that's very tall, a very large fontanelle, a broad nasal bridge, and hypotonia. They get seizures, and usually it's a fatal disorder. They have elevated very long chain fatty acids, but other things as well. And you really need a genetic panel. The new name for this is peroxisomal biogenesis disorder, but you're likely to see it as Zellweger syndrome. And there's no real treatment for this. Another disorder is homocystinuria. So this resembles Marfan syndrome because you have arachnodactyly, which is long, slender fingers. You can have a pectus, and you can have lens dislocation. This, of course, is often on the boards. It's down in homocystinuria and up in Marfan syndrome. That is not always the case, but we're talking about boards, right? So we got to go along with what people think. That's one of the things that differentiates this. But the other thing is that Marfan syndrome patients don't get thrombosis and strokes and developmental delay, and you do get this in homocystinuria. So this is an important disease to treat, and the homocystinuria patients don't get aortic dissection like the Marfan patients. Classic homocystinuria is a defect in cystathionine beta synthase, which is a pyridoxine-dependent enzyme. Basically, you get a very high homocysteine level, which causes all those symptoms. So you got to get rid of the homocysteine. And what you do is you restrict it with diet. You give betaine, which converts homocysteine to methionine. If you lower the homocysteine enough, their symptoms are much, much better. Smith-Lemli-Opitz, this is a cholesterol metabolism disorder. So it's in the synthesis. You have acetyl-CoA over here, and it goes through like 20 steps. And the very last step, when 7-dehydrocholesterol is converted to cholesterol, is blocked. Okay, so you have this enzyme, the sterol delta 7 reductase deficiency. Problem is cholesterol is an integral part of the central nervous system. So if you don't have it, you have microcephaly and you have other things. It's also a part of the developmental pathways. You get 2-3 toe syndactyly, but it's severe. That's where your toes are stuck together. You have polydactyly, where you have extra fingers. And then you have cleft. Cholesterol is used in synthesizing hormones, so you can have sex reversal. Males can have ambiguous genitalia. You can have a lot of behavior problems, and they have severe intellectual disability. So you can treat with cholesterol, but unfortunately, the real culprit here is this 7-dehydrocholesterol. And so there's not really any good treatment. So here's a couple of questions that relate to newborn screening. This, of course, varies from state to state, but I'm talking about the recommended tests that the federal government came out with. So which of the following disorders will be missed by newborn screening? Basically, I mean, there's just a list, which I'll show you. And glycogen storage disease at this time is not. Now, this time is May of 2021, and things may change. But this is the list of disorders that is screened for. There are some other disorders that are screened in some states, but this is the federal list. This is a screen. It's not diagnostic. Okay. Some of these disorders are secondary disorders, so they have no treatment. Some of these can present before the newborn screen. You need to still know about galactosemia because the newborn screen may come back after they're really sick. You need confirmatory testing. And again, different states may have different disorders. And if you're not in the US, different countries have different disorders, and many countries have very little newborn screening. Which of the following has an autosomal recessive inheritance pattern? So all of these are X-linked. Smith-Lemli-Opitz is autosomal recessive. Here's an example of inborn errors with abnormal smells that sometimes they test for macrocephaly, abnormal hair, eyes, etc. And so these are there for, to help you out if there's something that might be hard to differentiate. Thank you very much.
Dr. Derek Wong, inborn errors of metabolism.
But I am is
On the left. Are you able to home?
I'm cannot do presenter viewing
That one will work fine.
questions because I can't see it. Okay, so severe burning pains in his hands and feet. His mother has similar symptoms, and his maternal uncle has those symptoms as well as renal failure. This clinical picture is consistent with which condition? Okay, so we have these 5. I'll give you a few seconds. And actually, I'm going to do the discussion before we see the answer. So the thing is that, most of these are lysosomal storage diseases. And not all of them, some of them are other things, but at least Fabry, Gaucher, and Pompe. And it's important to really understand the symptoms of these because they're treatable. And so they do come up a reasonable amount. Fabry disease is an X-linked condition, and it presents with disease of the small blood vessels, which actually supply the nerves and other organs, especially the kidneys. And so people with Fabry disease often present in childhood with these burning episodes, and they can present later with renal failure. And so this particular question, they're consistent with an X-linked disorder and also has those symptoms. Gaucher disease, you have to remember, is really bone, right? So it will infiltrate the bone, and therefore you'll have pancytopenia, okay, especially thrombocytopenia, but also anemia, and you also infiltrates the reticular endothelial organ. So you get splenomegaly and then some hepatomegaly. So you get early, fractures, and you can get hepatosplenomegaly, and then the severe forms of this can have CNS problems too. But it's really bone that's the big thing. I'll get to glycogen storage disease in a second. Pompe disease is a lysosomal storage disease that mainly causes weakness. So some of these patients are so weak that by the time they're a year old, if they're not treated, they can only blink their eyes, which is really striking. Glycogen storage disease type 5, I put this in here because this is a muscular glycogen storage disease, and it can present with muscle pains, so sort of similar, but this is during exercise. It won't necessarily cause you to have renal failure, although I guess you could say that they're prone to rhabdomyolysis, but you do not get the severe burning pain in your hands and feet. You'll get pain in the muscles, the large muscles that you use. So that's not it. And then Zellweger syndrome is a peroxisomal disorder that really causes problems with a variety of things, but you get severe intellectual disability, intractable seizures, some dysmorphic features, and doesn't really present in this way. So the answer is Fabry disease. Now it looks like I have 3 Q&A. Oh yeah, okay.
Those are answers to this. Yeah.
Oh, I got it. Okay, so yes, you guys are good. See? So I'm happy. Okay, so then let's go to the next one. A female infant is born to a mother with PKU, and this mother was non-compliant with the treatment throughout her pregnancy, which unfortunately we see. Which of the following is a correct statement about the infant? So I'll let you read the answers there, and then I'll give you. We'll take a minute for some of this, and then we'll go over them. Okay, good. So we got some answers in there. So this is obviously a question about maternal PKU, right? Because the mom has PKU and it was uncontrolled. So therefore, the environment that the fetus develops in has a lot of phenylalanine, which is normally not there. Normally you have a low phenylalanine level in your, just like you do in the blood, but if you have PKU, you have a lot of phenylalanine. So let's go over the answers. So first of all, the infant should be put on a phenylalanine restricted diet. Well, the thing is, most of the time, the infant's not going to have PKU, right? Because the mom has 2 mutations and therefore has PKU. She's going to pass one of those mutations on. So the baby will usually be a carrier. Now you could say, okay, well the dad might be a carrier PKU, or he might even have PKU, but we don't know that. So there is a small chance that the baby will have PKU, but the infant shouldn't be put on a phenylalanine restricted diet until you know that they have PKU. So that's not really the answer. 2, which a lot of people got, is the correct answer, which is that maternal PKU causes intellectual disability, and it also causes microcephaly, in fact, because the brain just doesn't develop, because basically phenylalanine affects your brain, and the younger you are, the worse the effects. So if you're an adult, it has some effects on your executive function, but if you're a child, a small child, then it really affects your development and can lead to intellectual disability. If you're an infant, it's even worse, and it leads to abnormal development of the brain. So you get intellectual disability, microcephaly, and congenital heart disease. So it's a teratogen. Number 3, the infant has a 25% chance of having PKU. That's if it's a recessive condition, but in this case, most of the time you'll have a 0%. And if your partner carries PKU, you have a 50% chance. If the dad has PKU, you have a 100% chance, but you definitely don't have a 25% chance. So, and then number 4, if the newborn screening is normal, the infant will be normal. So it turns out that the newborn screening oftentimes clears amino acids, so it won't necessarily catch the mom's phenylalanine level. And so that most of the time the newborn screen will be normal on these patients, but the infant may not be. The infant may not be affected by regular PKU, but may have maternal PKU, which is basically permanent and untreatable, unfortunately. I mean, the congenital heart disease obviously treatable sometimes, but that's the answer. So that was good. Here's the next question.
a 3-year-old male has liver failure with jaundice as well as renal tubular acidosis. Workup shows markedly elevated urine succinyl acetone. The most likely diagnosis is. And I put this in because some of the, I remember some of the boards had this particular compound, succinyl acetone. So they do sometimes mention this. I'll give you guys a little while. Okay, so we've got some mixed responses here, which is fine. And we will look at the answers. So number 1, galactosemia. Now, galactosemia does present with liver failure and jaundice, but it does not have urine succinyl acetone. You don't usually get renal tubular acidosis. You get cataracts and you get E. coli sepsis, which is one of the things I mentioned in the talk. They're obsessed with that. So that's not galactosemia. Glycogen storage disease. Well, first of all, this is not a good question. I didn't mention which type of glycogen storage disease, but let's say we take type 1, and that usually doesn't cause liver failure for quite a while. It'd be very unusual for a 3-year-old to get liver failure. It does cause hepatomegaly, and it can cause renal tubular acidosis in some cases. But again, this compound is not consistent with that, and it usually shows up with hypoglycemia as the most dramatic presentation. This MCAD is the fatty acid oxidation disorder. So there's a couple presentations of this. Remember, fatty acid oxidation disorders present with hypoketotic hypoglycemia. That's the big thing with that, and that's not at least stated here. And then the other thing they can present with is basically sudden death, which used to be SIDS, but now it's known that some of these patients die during viral infections, and neither one of those is the case. So that doesn't match. Ornithine transcarbamylase deficiency. This is a urea cycle disorder. Urea cycle disorders usually present with hyperammonemia, but actually for those of you going into GI, they can occasionally present with liver failure, but they have abnormal amino acids. They do not have this urine succinyl acetone, and usually males will present with hyperammonemia, which will be the dominant feature. So it is sort of related, but not really. This is the right answer, tyrosinemia type 1. So this is the one that the type of tyrosinemia that's called hepatorenal tyrosinemia. This is the one that's screened in some states, but not necessarily completely, because some states use tyrosine, they don't use succinyl acetone, and tyrosine can be elevated for a variety of reasons. So the bottom line is, when you see succinyl acetone, it means tyrosinemia. And like I said, normally I don't put all these chemical names on there, but I have seen several questions maybe it was a long time ago when I was taking the boards, several questions about that. So that's the answer. Okay, so that's tyrosinemia. And the next question is a 2-day-old who is lethargic and then comatose, has an ammonia of 1,000, which for those of you who've worked during your residency, that usually scares people. It scares me still. That's really bad. And a venous pH of 7.37. So which of the following is the most important next step? And that's next step. That's like crucial. Is what you want to do something for this patient. You might be doing a lot of these things, but I want to know what you want to do first. Okay, so we have some good answers here. So remember from the talk, when you have hyperammonemia, okay, especially those of you going into NICU or actually into hospitals too, if you have a baby who's hyperammonemic, you really want to know, is it a urea cycle disorder or is it an organic acid problem? Okay, and some people forget, and it's reasonable because we forget everything. Like I forgot, a lot of things by the time I was done with my PEDS training. But it's easy, right? If you an organic acidemia, almost by its name, often causes acidosis, at least the ones that we talk about commonly, like propionic acidemia, methylmalonic acidemia. You have a severe acidosis. So your pH is usually going to be 7, 6.9, or something like that when you're sick. Okay. If you have a urea cycle disorder, oftentimes you'll have normal pH, or you can have some alkalosis. In this case, but obviously you can have acidosis in this, but they're not going to put that on the test. So if you have a very high ammonia and a normal pH, chances are you have a urea cycle disorder. Okay, so that puts you in one category. And remember these questions, right? They oftentimes want you to diagnose something, and then they want you to analyze it. So then the question is, how do we treat the different things? So what is carnitine used for? Carnitine is used to detoxify things. So if you have an organic acid problem, you take carnitine, it takes that propionic acid or methylmalonic acid, and it gets it to a state where you can pee it out. So it's a detoxification system. It does not affect ammonia. So carnitine is not really used in a urea cycle disorder, whereas it is in organic acidemia. So since we think this is a urea cycle disorder, carnitine is not used. Number 2 is dialysis. Dialysis is the most important thing, whether you have an organic acidemia or whatever your source of your ammonia. This is the thing that's going to save you, right? I cannot remember if I said this in my lecture, but I tell the residents this all the time. The brain damage that happens if you have a very high ammonia is proportional to the height of the ammonia and the length of time. And I'm talking matter of hours. So if you have an ammonia of 1,000 for 14 or 16 hours, that's a big problem. You can take a permanent hit to your development, and some people will die if you have it for too long. Okay, and so the fastest way to get this down is dialysis. You drop it, and you just drop it as fast as you can, and then you deal with the rest of it as after you do that. So this is in many cases this is the right answer. In this case, it also is. Genetic testing. Well, of course, even in the era of faster genetic testing, this is going to take a week or two. For some of you who are in certain institutions, they say they could do it in a day, but that doesn't matter. If you do genetic testing, you're sitting there waiting for results. This kid's going to be either very damaged or dead. Special metabolic formula. That is used in both organic acidemias and urea cycle disorders. But if you have someone that sick, they're going to be in extremis. They're not going to be able to eat. Especially, I mean, you can sometimes NG someone in a coma, but usually they're intubated, or something like that. And so and metabolic formula is not going to work that quickly, right? That's more of an outpatient treatment. And this is a acute treatment, so that's not the answer. And then organic acids, that is useful in diagnosing organic acidemias, and it also sometimes contains orotic acid, which can be useful in urea cycle disorders, but that doesn't come back for at least hours to days. Sometimes it takes at least a few days to come back, and sometimes a week. So that's not going to help you right away. So the idea is very high ammonia, dialysis first, and then everything else after that. So okay, last question. A 5-day-old infant has lethargy and coma. It's a common theme today. I hope that you guys don't feel this way after lunch. She has a sweet odor. The labs are pretty normal. Okay, there's no acidosis, and the ammonia is okay, and glucose level is normal. Which of the following tests is likely to be diagnostic? Now I'm going to give you a hint. This is an inborn error of metabolism, no duh. So you guys can have a minute at this. Okay, so this is another one of these questions that you could argue you can get various answers, but this is another question where you try to figure out what this patient has, right? So she has a sweet odor, so that and the fact that there's not really a lot of abnormalities in the labs, that's consistent with maple syrup urine disease. And I was going to put smells like syrup, but that's a little bit too obvious. Okay, we did have someone who came in and they sniffed the room and they said MSUD and bolted out. This is one of the genetic attendings who was a little bit autistic, which I won't name this person because that would be bad. But anyway, so MSUD is notorious for not having very many lab abnormalities. Now you can have some ketoacidosis, and you can in really bad cases have hyperammonemia, but many times you don't have that. By the time you have the odor, it's pretty bad, and unfortunately this sometimes comes back before the newborn screen. So it turns out that some of these. This is a disorder of branching amino acids, and some of these things can be diagnosed by urine organic acids. But in fact, the block here is so close to the amino acids that it's the amino acids that are toxic. And in fact, leucine is extremely toxic. So this is the thing that sometimes you need to dialyze leucine off, and your whole strategy is to treat the leucine level. And so the plasma amino acids is the most important thing, and actually gives you prognostic value. There's acetylcarnitines, which can diagnose a variety of different metabolic diseases, but in this case, it's usually fatty acid oxidation disorders and some other organic acidemias. Carnitine levels, not really useful in this case, and very long chain fatty acids. These are used in peroxisomal disorders, for example, X-linked adrenoleukodystrophy or Zellweger, not necessarily this. And organic acids is a good guess, but in this case, it's the amino acids. Okay, so I am done. I apologize for the technical difficulty.